Hi, everyone. Welcome to the third episode of Our New Viral World. I'm Makeda Robinson. I'm an infectious disease specialist at Stanford University. And today I'm going to talk about the diagnostic dilemma surrounding COVID-19. I'll be discussing some of the different types of diagnostic tests, as well as how we test the accuracy of those tests and how that's led to confusion around the actual number of COVID-19 cases. Given that there's currently no vaccine available to protect those people who have not yet been exposed to the virus, and there's no silver bullet treatment for those who have already been infected, diagnostic testing has become the foundation of how we can actively work to prevent transmission of COVID-19. Because of this, COVID-19 diagnostic tests have been used to ask multiple different questions that have been raised by the pandemic, including whether or not someone has an acute active COVID-19 infection, as well as if that patient with an acute infection has fully recovered from their initial illness. Diagnostic tests have also been used to identify previous infection to determine how many people may be immune to the virus. These tests have also been used to screen asymptomatic infections, so people who have no signs or symptoms of illness at all may still be infected with COVID-19 and are also able to transmit the virus to other people. And this may be part of the reason why this virus has been able to spread so quickly. And additionally, these tests have been used to identify the percentage of people in the population that have been exposed to the virus already, which helps us to understand what a second wave of infection may look like. In order to discuss the accuracy of the diagnostic tests for COVID-19, I first wanted to introduce a couple concepts, which include the sensitivity of the test versus the specificity of the test. This is going to require a little bit of math, but don't worry, we're going to get through it together. The sensitivity of the test is calculated using these two boxes on your left-hand side. So these are the true positives, so those who have COVID-19 who test positive for COVID-19, and the false negatives, so those who have COVID-19 but test negative for COVID-19. So the sensitivity of the test is really looking to see how well the test identifies COVID-19 patients as having COVID-19, so that we're not missing cases. The sensitivity is calculated by the number of true positives divided by the number of true positives plus false negatives. So the sensitivity of the test is really driven by the number of false negative results the diagnostic test returns. The specificity of a test is used calculating these two boxes on your right-hand side. So those are the false positives. So those are people who do not have COVID-19 but test positive for it, and the true negatives. So those who don't have COVID-19 and test negative for it. The specificity of the test is calculated by the number of true negatives divided by the true negatives plus the false positives. So again, the specificity of the test can really be driven by the number of false positives that this test is returning. So the number of people who don't have COVID-19 but are testing positive for it. And I'll discuss later on why a diagnostic test may return false negative or false positive results. The first of the two major classes of diagnostic tests that I'll talk about today is a reverse transcription polymerase chain reaction, or RT-PCR assay. This requires a sample that's either taken from the nose or the back of the throat to evaluate if there is COVID-19. And this specifically is looking to see if there is viral RNA. And here the nomenclature can get a little bit confusing. So RT-PCR assays are also called nucleic acid tests or molecular tests. Once the sample is obtained, it then undergoes a reverse transcription process. So as we talked about before, DNA can be transcribed into RNA, and that RNA can then be translated into proteins. But RNA can also be reverse transcribed back into DNA. And that DNA is then called cDNA, or complementary DNA. And in order to do this, we need a special enzyme called a reverse transcriptase, whose specific function it is to turn RNA into DNA. The second phase of this assay is the PCR, or polymerase chain reaction. And here we have primers that are complementary to the DNA sequence and a specific enzyme called a polymerase, which can then make a complementary strand to the DNA. And this can be amplified multiple times, and we can then measure that signal at the end of the PCR reaction. The second major type of COVID-19 diagnostic tests are called serology tests or antibody tests. And specifically, these are measuring our human immune response to viral infection. So when someone's infected with COVID-19, those viral antigens can come into contact with a specific immune cell called a B cell. These B cells then interact with another immune cell called a T cell. And this T cell starts to send signals to the B cell that you have to start becoming an antibody making machine. And so those B cells then mature into a plasma cell. And these plasma cells just churn out a lot of antibodies. And that's what's being measured in a serology test, is the antibodies that our immune system is making specifically to COVID-19. So there are, of course, pros and cons to either one of these approaches. And really, I think you can think about these as complementary approaches because they give us different information. So I know that many people are getting one test, but you can also get more information about that person's exposure to COVID-19 by combining these tests. As nucleic acid tests really tell us more about current infection. For antibody tests, they're testing past exposure to COVID-19. So these are the tests that help us to understand, has someone been infected or exposed to COVID-19 and now have antibodies to that? And therefore, are they more immune or at least resistant to more severe disease? And as many of you may have read, many hospitals are now beginning to start screening all of their healthcare workers to evaluate if they have been exposed to COVID-19 or not. Because those who have been exposed already may have antibodies that make them immune or at least more resistant to COVID-19 infection. It also can help to tell us how many people may have been infected without knowing it. And that gives us a sense of, one, how many asymptomatic cases there are, and what the herd immunity in our communities is. I think that these graphs are really useful in understanding why a diagnostic test may have a higher false positive or false negative rate. So for example, if someone's infected with COVID-19, they may not realize it for a few days and not have symptoms, but during that time, the viral RNA levels will begin to rise. However, these levels do not stay at this high amount throughout the course of your illness, right? They'll begin to slow down and decrease. However, while they're beginning to decline, our immune system is starting to rev up. So this is when we're able to detect antibodies to COVID-19. So first, we'll be able to detect IgM, which is an early antibody. And then second, we'll be able to detect IgG. And while IgM levels will often peak and then fall back down, IgG levels tend to remain high. So we can detect this later on after the person has recovered. So when you're looking at this table, where do you think somebody may test negative for a COVID-19 when they actually have the virus? So for an RT-PCR test that's testing viral RNA, if you test somebody too early on in the course of their infection, they may have a false negative test. And again, if you test them too late in the course of infection, so some studies have shown after 10 to 11 days after symptom onset, it may be harder for us to detect the viral RNA. You may again have a false negative test. And for antibody tests, you can see it takes some time for our immune system to begin to work and to start making antibodies specifically for COVID-19. So if you test someone anywhere in this window, they would have a negative antibody test. And again, that's why I think that these two tests can really be complementary, because they give us different information at different times. Because after the viral RNA declines, we can then detect the IgG for a long time afterwards. And this is what we're testing when we're asking ourselves, has someone been exposed to the virus, and do we think they have immunity to the virus? When you're detecting the virus by RT-PCR, We don't know whether that's actively replicating virus or that's viral RNA that's debris that's not actually able to infect other cells. So even if someone does have a positive PCR test later on, that doesn't necessarily mean that they have infectious virus. Also, this will relate to the questions of whether or not we can get reinfected with COVID-19. Initially, as I mentioned at the beginning of the video, these diagnostic tests don't just diagnose acute infections, but oftentimes once someone has been acutely infected, there will be a subsequent test to evaluate if the patient has recovered. So if someone has a nucleic acid test that's positive, they may then test again to see if that test is negative. And they usually require 2 negative tests in order for someone to be called recovered from COVID-19. And what seems to be happening is that while their people will initially be positive, they'll then have a negative nucleic acid test, and then the second evaluation for them will be positive. The question here is the person reinfected, or did something happen that triggered a bump in viral RNA that's now in detectable range? When thinking about antibody tests, we know that oftentimes these tests may not be as specific as we would like. For example, I study dengue and Zika virus, and we know that some people with Zika virus will test positive for dengue serology tests, meaning that these antibodies may cross-react. And there was a recent Lancet article that actually showed 2 patients who had a positive dengue antibody test that were actually found to have COVID-19. So we know that there may be some issues here where these antibody tests may not be as specific as we would like. And that may make it more difficult for us to understand how many people have been exposed to the virus. So there was a recent article that came out from Stanford University that's on another archival site that's gotten some comments regarding the accuracy of the test that was used. And part of that question is really about what is the level of false positives in some of these serology tests. And so lastly, I did want to touch on the question of whether or not we can get reinfected with COVID-19. Honestly, I think the jury is still out. I don't think we know. But there is a study that's begun to be cited a little bit more frequently that was published in bioarchives. This is a study using rhesus monkeys. They used 4 monkeys. They initially infected all 4 of them with COVID-19, and they found that these monkeys demonstrated symptoms of COVID-19 and had detectable viral loads. They then waited 28 days and infected only 2 of the monkeys again, so M3 and M4, and evaluated for any symptoms of COVID-19. And these 2 monkeys did not appear to have any difference in their body weight. They did not have a detectable COVID-19 viral load in their samples. They both did have a slight temperature, but that was the only real symptom. And so here they concluded that it's unlikely that we are able to get actively reinfected with COVID-19 so early after being infected initially. However, I do think another important concept to think about here is there may be different strains now of COVID-19. It's unclear if you get infected with a different strain if those antibodies that you've made to your initial COVID infection will be able to fight off this different strain. So more to come here, put a pin in that. I think there will be some more really interesting research that's done around this question. So I know throughout this time, people have been very interested in understanding how they can help. And as more diagnostic tests are being performed and more people are beginning to know their COVID-19 status, I think one thing that people can do who were told that they have been exposed and recovered from the virus is to go to this link by the Red Cross, and they're asking for donations of blood from people who have fully recovered from COVID-19. The antibodies in your blood to COVID-19 may help to neutralize the virus, and therefore they're being used as treatments for people who have severe disease. So for my next episode, that's what I'm really going to focus on is what are the treatments that are really available now for people who are infected with COVID-19? Are they only for people who have severe disease, or are they given to people with mild or moderate disease to prevent them from developing severe disease? And what is the data on how efficacious many of these treatments may be? So thank you again for taking some time to listen about the diagnostic dilemmas. Please subscribe below and leave any questions that you may have. Thank you so much and hope you're all staying safe.